The aim of this short video is to focus on some of the key steps you can take to deliver high quality urgent and emergency care. Poor processes along the pathway lead to congestion in emergency departments, crowded hospitals, harm events and high costs. Our aim needs to be to get patients better, faster and safer. This requires the focus and integration of the entire local health community, with each partner organisation and department doing its bit. Having carried out reviews in more than 50 local health communities, the intensive support team believe there are a number of key areas that can make a significant positive impact on the delivery of high quality patient care and cost reduction. Today we are talking with Dr Ian Sturgis, the clinical lead of the Urgent and Emergency Care Intensive Support Team. Dr Sturgis is a physician at the East Kent Hospital's University NHS Foundation Trust. Ian, you've often said that you strongly support clear access standards for emergency department, which many clinicians find a turn-off. Why do you support such standards?
Well, the prime reason for having the access standard in the first place was to drive up quality so that patients can get better, faster and safer. Patients who just wait for the next thing to happen are not getting a high quality service. We need to make sure that patients who present with emergency conditions get the treatment they need as quickly as possible.
You say that delivering better, faster and safer care in emergency departments is about whole system delivery. What advice can you offer to PCT chief executives to help them lead their local health communities to deliver this agenda?
I think one of the most important things that PCT chief executives can do to support delivering high quality emergency care for patients is to make sure that their whole system is involved and that there's appropriate alignment of services and that each element of the service is held to account to be making sure they are delivering what they say they're going to deliver for those patients, so that patients aren't left out in the community not knowing where to turn to. I think the other thing that PCT chief executives can do is to make sure that they understand the measures that can tell them whether their system is working effectively or not.
Emergency department attendance and ambulance journeys are constantly increasing, and some experts are of the view that we should accept this and increase resources in emergency departments and hospitals to cope. What's your view?
Well, first and foremost, we need to understand why more patients are turning up at emergency departments. Clearly, there are more patients becoming more sick, but some patients turn up to emergency departments because they've been unable to access services earlier in the day or earlier in the week, and their condition may well have changed or deteriorated, or they've become more concerned about their condition. If those services were more responsive in the community, they could be reassured and be treated and wouldn't need to turn up at the emergency departments. But let's be very clear, when patients do turn up at the emergency departments, we do need to make sure that there are the resources there to be able to manage them safely and effectively.
Now, many health communities are creating single points of access and comprehensive directories of services. We asked Bernie Edwards, Intensive Support Manager, whether she thought this was a sensible direction of travel.
In terms of single point of access and a comprehensive directory of service, yes, I absolutely do support this. 95% of unscheduled care is actually delivered in the community, and it's delivered by a multitude of individuals and services, and we have to get better and smarter at aligning those services so that we minimise waste and we maximise efficiency. If we have a system that is complicated to access, then people will navigate their way to the point of least resistance, which is and will continue to be emergency departments. A good single point of access should be available 24 hours a day, 7 days a week. It should navigate referrers to the right part of the system to ensure that patients get the right care in the right place at the right time.
So Ian, the vast majority of care is provided outside of hospitals by primary care. What contribution do you think that GPs can make to improving urgent care without defaulting to referral to emergency departments?
Well, I think we do need to recognise that 90 to 95% of urgent care does occur outside of hospitals. And the implications of that is that even if a small reduction in that 90 to 95%, you may not notice it too much in the community, but it will have a significant increase on the volume of patients that are turning up at emergency departments. There's a lot that primary care can do, and the work from Dr David Carson of the Primary Care Foundation about urgent care in primary care demonstrated by making sure that they had the capacity to answer telephone calls, that they made sure they had the right profile of appointment slots and the right way of managing visits for patients at home can have a significant impact not only on patients, the time that patients turn up to hospital, but also on the total number of patients that go to hospital as well.
Now, anyone who has heard you speak will know that you emphasise the importance of using high quality information to improve patient care. Can you give us your top tips for using information?
Yes, I mean, information is absolutely crucial to be able to monitor what you're actually trying to achieve for patients. And what key things we need to be looking at are outcome measures, how the patients actually are dealt with, how they get better. But we also need to look at some process measures, those measures making sure that the processes that we're actually doing are actually happening the way that we want to make sure they're happening. And finally, we also need to make sure we use some balancing metrics, i.e. measuring those unintended consequences of any changes that we might bring about. Some of the key information that we seem to lack still in the country is how much demand there is out there for urgent care. There's clearly a lot of information within ambulance services about demand for ambulances. We know the demand in emergency departments, and we know the demand for out-of-hours services. But actually understanding the demand across the rest of the system is fairly lacking, and we need to get much better information about that so that we can then make sure that we have the right services to manage that demand in the right place at the right time.
You are a keen advocate of what you term internal professional standards. Can you tell us more about these?
Well, I think the best way to describe the internal professional standards is to say this is how we do business around here for the sake of our patients. It's about saying, you know, when you're coming into hospital, how quickly you're going to be seen. There's one hospital in North America, for instance, that says, you know, door-to-doctor time, 30 minutes. You know, seeing a doctor within 30 minutes of arriving in an emergency department or in an assessment unit, I think it's very important for patients to know that they are being seen and somebody's taking a keen interest in what's wrong with them and will help to get them better, faster and safer. So the internal professional standards are about saying this is how we want you to be treated in this organisation so that you have the reassurance that we will get you better, faster and safer.
The intensive support team has recently published a paper on managing patient flow in acute hospitals. Can you tell us why it's important to get patient flow right and some of the principles we should bear in mind?
Well, one of the problems if you don't get the patient flow right is that patients end up in the wrong beds or in the wrong place in a hospital and are not being nursed or looked after by the right teams of doctors and nurses and therapists to get them better. So we do need to understand the flow streams within our hospitals. There are roughly 3 or 4 flow streams. There's short stay, so you come in with a mild to moderate illness that can be fixed fairly quickly and you should be able to go home within 1 day or 2 days. There are those patients who have true specialty needs. They need to go to a heart specialist or a chest specialist, so they should go directly to those services. There are those patients who it's not absolutely clear straight away what's wrong with them, who are generally unwell, but they need to be looked after by people who are experienced in general problems. And then there's the complex group of patients. Predominantly these are frail older people who have multiple other illnesses, comorbidities, that really impact on their acute illness, and they need to be identified very early, have their acute illness fixed very quickly so that they don't deteriorate because they're in hospital. One of the things that can happen to frail older people is that if they are lying in a hospital bed too long, they get weaker and weaker and their mobility is affected and they then start to get other illnesses as well.
And Ian, many clinicians find it difficult to set expected dates of discharge for their patients, but you set both a date and a time.
Well, first and foremost, you know, they are professional standards about setting expected dates of discharge. For instance, the College of Physicians has made it very clear that every patient admitted to hospital under a physician should know their expected date of discharge within 12 hours of being admitted to hospital. So it's a professional standard. It's not my standard, it's a professional standard. But the purpose of the expected date of discharge is to say to the patient, look, this is what's wrong with you. This is what we're going to do to get you better. This is when we aim to get you home, and we will make sure that all those things that are necessary to get you better and those things that need to be set up to safely get you home will be done by this date. Of course, if their recovery is a little bit longer, we can always extend it, but it's about giving an aim. There's nothing worse really for a patient to be in hospital 4 or 5 days not knowing when they're going to be going home, and then on the day they are going to go home, somebody says, now you're going to go home. It comes as a bit of a surprise. So I think creating that expectation and the patient knowing what's wrong with them, what treatment they're going to get, how the recovery is going to proceed, and when they're going to go home is very reassuring for the patient.
And you're the author of the NHS Institute's Directory of Ambulatory Emergency Care for Adults. Could you outline the principles behind emergency ambulatory care and give us an example of where it works well?
Well, the best way to describe the principle behind the Directory of Ambulatory Emergency Care is to consider elective care. We've changed the way we deliver elective care. Previously you used to come in for a planned operation, stay for a few days and then go home. Now, vast majority of surgery is done as a day case, and that what the directory describes is a process of delivering emergency care as a day case rather than staying for prolonged periods in hospital. The idea of the directory came to me when I visited South Tees University Hospitals Trust in Middlesbrough, and I met Dr Dr Connolly, who was delivering really effective ambulatory emergency care there.
Excellent, so let's hear what Dr Connolly's got to say.
Here at the James Cook University Hospital, we've operated a system of ambulatory emergency care for some 10 years now. It started initially with fairly low-key amount of work relating to the outpatient management of deep venous thrombosis. But as the years have gone by, we've layered that up and added a variety of medical presentations and conditions to that, such that we now manage pulmonary embolism, heart failure, patients with upper GI bleeds, asthma, bronchitis and so on through the ambulatory emergency care clinic. We've had to develop the facilities for that over the years, and we've put in place consulting rooms and trolleys to enhance the environment for providing this care, because initially we provided it in a room just off the acute assessment unit. It's been a great advance for us because it's managed to divert a lot of patients away from going directly into hospital beds. So our bed managers will intercept calls from general practitioners and from their clinical expertise direct them round to the clinic. And the other way that patients get access to the service is directly from A&E, where we use either protocols or a phone call referral system for the A&E team to book patients into the ambulatory care clinic. And at that point they can be followed through in a protocol by a nurse practitioner, or a senior clinician can be called on to give advice about the further management of those particular patients. It has diverted over the course of the year several thousand patients away from the acute assessment unit. And without that facility we would be using an additional 3 hospital wards. I think it also improves patient care because they're more likely to see a specialist early on in their journey through the emergency care pathway, and they're also seeing nurse practitioners who are expert and have a lot of experience in managing these particular conditions. Without it, I don't know how we would accommodate our emergency care patients in the Trust.
And finally, Ian, could you summarise your top tips in delivering better and safer urgent and emergency care?
Well, first, I think the most important thing is to recognise that this is a whole system issue. It's not just about the emergency department or not just about the hospitals. It's about primary care, community services, mental health, social services and obviously the hospitals as well. So the whole system has got to work together better in a much better integrated manner to be able to get patients better, faster and safer. Secondly, I think it's crucially important that we have much better understanding of the demand on our services so that we can truly map the capacity to that demand so that patients can access the services they require as and when they need it, rather than defaulting at times to the emergency department, or worse still, waiting for a day or two, deteriorating and then having to go to an emergency department because they're so ill. Third thing I think we need to be thinking about is how do we get much better integration of services. There are so many services out there that it feels a bit much like a patchwork of services, and sometimes patients fall between services and are excluded from services for really no good reason. At other times, patients can have 4, 5 or even 6 visits a day from people asking the same sorts of questions. So we do need much better integrated working across the system so that patients get the services they require when they need it. And finally, I think one of the most important things is we need to focus on the quality of services that we're providing and the quality of the outcomes for patients. Because if you develop an acute illness, it must be one of the most frightening periods of your life. And what you need to know is there's a service out there that will scoop you up, fix you, get you better and reassure you. And at times, we have to be honest, it doesn't feel like that. And patients sometimes get lost within our services and don't really know who to turn to. So I think we've really got to focus on the quality of the outcomes and better integration of services.
Well, thanks very much for taking the time out to talk to me, Ian.
Thank you.
So this is all about high quality care, aiming to get patients better, faster and safer. Thanks for watching.